Welcome, everyone, and thank you for participating in the Pebbles of Hope inaugural webinar series commemorating National Prematurity Awareness Month. I'm Cheryl Chiltrani, and I'm the Executive Director of Pebbles of Hope. This is the final session of our November webinar series. For those of you that don't know, our series this month consisted of 4 sessions, all covering topics related to preemie nutrition. The Pebbles of Hope mission is to help premature babies thrive through parent education, and the webinar series is the first step towards achieving that goal. To learn more about the organization and our activities, please visit our website at www.pebblesofhope.org. We really appreciate your support and hope that you will find this an informative session. I'm delighted to introduce to you our speaker for today. Dr. Bonita Wilson is a board-certified pediatrician and allergist with more than 40 years of clinical experience. She is currently in practice at Allergy Partners of Fredericksburg, Virginia. She obtained her MD degree from Howard University in 1976 and started her pediatric residency at Boston City Hospital. Her residency was interrupted by the birth of premature twins and the subsequent death of one of her twins. She completed her pediatric residency at DC General Hospital and then served as chief resident of pediatrics there, where she spent considerable time in the NICU. After her pediatric residency, she completed a 2-year fellowship in allergy and immunology. Before we get started, I have just a couple of housekeeping matters to go over. All attendees will be muted for the duration of the session, but after the presentation, you will have the opportunity to submit a question. Just type it into the chat screen, the chat box on your screen. I will then read out the questions at the end to Dr. Wilson, who will answer them as time allows. With that, I will hand it over to Dr. Wilson.
It's my pleasure to be part of this informative webinar series. I hope that you will find this talk informative and useful. Today, we're talking about food allergies and sensitivities during infancy. And I separate that, allergy and sensitivity. As you see on the first slide, there are many types of adverse food reactions. And the most general term that is used for an adverse food reaction is an allergy. Most people, when they aren't able to tolerate something, they'll say they're allergic to it. But in actuality, an allergic reaction is an abnormal response that involves your immune system. The immune system consists of the antibodies that your body makes and the cells that are used in your body to fight off infections and foreign materials. So an allergic reaction is an actual abnormal immune response. There are many other ways that you don't tolerate a food that do not involve the immune system. We call these non-allergic reactions. And there are some examples that we will go through. Now, in an allergic reaction, you produce an antibody. We call this the allergy antibody or an IgE antibody, and it interacts with certain cells in your body that contain the products that cause your symptoms. And this is a very quick thing. So allergic reactions are very fast, very rapid. When you have an allergy to a food, it's usually within 15-20 minutes of exposure to that food that your symptoms will begin. And the symptoms usually involve the skin. It can involve the respiratory tract, and you can have difficulty with breathing or swelling with difficulty in swallowing. It involves the gastrointestinal tract, where you may have vomiting and diarrhea. And it can involve the cardiovascular system, where your blood pressure may fall and you may have problems with passing out, fainting, things like that. These reactions are involved against proteins in the food. So people generally are not allergic to the sugar portions of food or the fat portions of food, but to the protein portions of food. Now, there are other types of sensitivity reactions that do not involve the allergy antibody, but still involve other aspects of the immune system. And I listed some examples here, which we will be discussing later on in the presentation. Now, as far as non-allergic reactions, many people have had problems with lactose intolerance where they can't tolerate milk and they get very bad crampy stomach pains, diarrhea. They become very sick, but that's not an allergy. If I were to do an allergy test on someone with these types of symptoms for this reason, their allergy test would be negative, yet they cannot tolerate milk. And that's one example of a non-allergic reaction. Other things such as reflux, or people who have irritable bowel syndrome, people who have a virus that causes them to have gastroenteritis, and often in infants we'll see irritant reactions because the skin of an infant can be very sensitive. And when they put food all over their faces when they're eating or spill food all over their bodies, they may develop rashes that are more irritant in nature. So in general, you'll see that there are many types of adverse food reactions. We're going to concentrate in this talk on the immune reactions, the allergic reactions involving the allergy antibody, and those sensitivity reactions that do not involve the allergy antibody but involve other aspects of the immune system. Now, with an allergic food reaction, these, as we said, these reactions occur within seconds to minutes after exposure to the culprit food. And we discussed many of the symptoms, vomiting, diarrhea. Rashes are very frequent. And you see a picture here of an infant who's broken out into a hive-like rash. This is a welty, irregularly shaped, usually a reddened type of hive-like rash that tends to be itchy. And an infant may have difficulty in scratching, but they'll become fussy. They may be trying to move around a lot and squirm around in an attempt to scratch their itchy skin. They may have all of these symptoms or only one of these symptoms. And sometimes it's often difficult to determine that an allergic reaction is occurring if the skin is not involved, because there can be other reasons why your infant may have vomiting, diarrhea, or wheezing, and also other reasons for breathing difficulties. Now, the most common foods that will cause a problem in infancy are milk, soy, and egg. These are the most common food allergies in the infants. Now, other foods can be involved, but they are less frequent, and infants who are being breastfed sometimes can be sensitized to other foods through the breast milk or even through direct ingestion when other younger siblings may be putting food in the infant's mouth. The infant that's crawling around on the floor, grabbing pieces of food and ingesting it, or other adults who want the infant to taste certain foods. So there are many ways that infants can be exposed to foods that aren't a usual part of their diet and make them at risk for developing less common food allergies. Now, if an infant is suspected of having a food allergy, they should be evaluated by an allergist to determine what the culprit food is. Once you have developed an allergy to a food, the consequences can be quite serious if you're exposed. So it's very important to document that there is an actual food allergy so that the appropriate treatment can be made and that unnecessary restriction of an infant's diet is not recommended. The strict avoidance of the culprit food is the hallmark in treating food allergies. And counseling is very important in recognizing the signs of an allergic reaction in the event of an accidental exposure. Usually, when caregivers are aware of an allergy, they're going to make every effort to avoid exposure. But unfortunately, these accidental exposures are not rare. When you see an infant that's developing a rash, having difficulty with breathing, sudden onset of intestinal upset with vomiting, diarrhea, becoming lethargic and unresponsive right after exposure to a food, then an allergy should be something that is thought about. When the child has a known allergy, then usually some available treatment, such as available epinephrine, is available with clear instructions on how it is to be used and when it should be used. And antihistamines, such as Benadryl, are also available when a known allergy exists. Now, epinephrine is the hallmark of treatment for acute severe allergic reactions. When infants have severe reactions that involve reduction in their alertness, significant rash, breathing difficulties, and vomiting, that type of allergic reaction needs to be treated immediately with an epinephrine type of injector. There are two that are available on the market. One is called Auvi-Q and one is called EpiPen. And people with food allergies are generally familiar with these devices. They're very easy to use. The Auvi-Q will talk to you and it tells you exactly what to do, but both devices have information printed right on them with clear instructions on how to use these products. The epinephrine is injected into a big muscle, so we use the thigh, and this is done even through clothing in an emergency. But if it's easy, then doing it directly on the skin would be the preferred method. The auto-injector puts in a dose of epinephrine, and there are two dosages that are available. In an infant, you would always be using the smaller dose or the junior dose. There is a larger dose for older children and adults. And people wonder, well, why would my infant be getting the same dose as someone who is 3 years old or 4 years old? And it's always better to overtreat than undertreat in these situations. The epinephrine is part of a natural hormone that is released in response to stress, and it's the hormone that will cause people to have a rapid heart rate and an elevation in blood pressure, and we're administering extra to cause some narrowing of the blood vessels to reduce the absorption of the allergen. Infants tolerate this very well, even better than older people, because infants don't have conditions of high blood pressure and heart disease, so you don't have to be as nervous about administering epinephrine when an infant is having an allergic reaction. It's very important to do so. Now, how can people go about trying to prevent their baby from having a food allergy? And this is a frequent question, especially in families where allergies are prevalent and food allergies are a higher risk. The infant who has a parent with allergies or a sibling that has food allergies has a much higher risk of developing a food allergy, and that would be an infant who would be considered high risk. One of the ways that we recommend in reducing that risk is to provide breast milk for infants that are at high risk for developing food allergies. And breast milk has many, many benefits in infants, especially in premature infants, and one of the many benefits can be the reduction in the manifestation of food allergies. The allergic reaction will occur because the person's immune system has been directed in the direction to have an allergic reaction rather than in the direction to help prevent and treat infections. So when you have breast milk, there are certain properties in the breast milk that help to guide the immune system away from the allergic profile back to the more normal profile where the immune system is fighting off infection. The breast milk also helps to protect the intestine against harmful organisms and provides more beneficial organisms that will stimulate that beneficial immune response, meaning that these probiotic organisms help the baby have an immune system that is going to be more in tune to fighting infection than to producing allergic reactions. there are certain proteins in foods that are more likely to cause a person to have an allergic reaction. We call this sensitizing proteins, proteins that make you sensitive. And these proteins can be absorbed more readily in an infant gut because the infant gut doesn't always have the barriers in place. The infant gut is not fully developed. So some of these proteins will pass through and get into the bloodstream and have a capability of causing you to become sensitive. Breast milk has products in it that help reduce the absorption of these sensitizing food proteins to make you less likely to develop the allergy. And studies have shown that when infants are exclusively breastfed for at least 4 months, they have a significant reduction in their risk of cow milk allergy. And cow's milk allergy is the most common food allergy that we see in infancy. Now, when you have an infant who is allergic, then, as we mentioned, our best recommendation is breast milk. But sometimes breast milk is not available, and there can be many good, valid reasons why a mother is not able to provide breast milk. There are sometimes when even breast milk will cause introduction of sensitizing agents to the baby. We have sometimes found that when a mother is drinking milk or a mother is eating egg, her baby can become sensitized and the mother will need to eliminate the milk or eliminate the egg from her diet. And if a mother has to eliminate milk, that can usually be done without too much difficulty. But sometimes if multiple allergens are found and the mother has to make significant changes in her diet, it's simpler to put the baby on a formula that will not allow the baby to be exposed to sensitizing proteins. And there are several formula options. We call these elemental formulas. These formulas do not have large protein particles in them. They have the protein building blocks that are called amino acids. They still are very good formulas that will provide all of the vitamins and minerals and calories, the appropriate amount of fat and carbohydrates or sugars that are needed for proper infant growth and nutrition, but they don't contain the types of proteins that will expose the baby to allergies. And these are some of the samples in this slide. Now, in a high-risk infant, you would want to use these elemental formulas, or they're called hydrolyzed formulas, in place of the traditional formulas. In years past, it was thought that if you used a soy protein formula, that this would help to prevent allergic disease, and it has subsequently been shown that this is not the case, that using soy-based formulas do not prevent allergic disease. In fact, soy is the second most common allergen that we see in infancy. Now, solid food at some time is going to be introduced into the life of your infant. And how should this be done? There are ways to introduce solid food to help reduce the risk of allergies, and there are some foods that should be delayed in an infant that is high risk for developing allergies. Under normal circumstances, you're not going to be introducing solid food before 4 to 6 months in all infants. Some infants, particularly those that may be premature, may need some degree of solid food prior to 6 months of age, and infants who have certain conditions such as reflux may benefit from some addition of solid food before 6 months of age. But in general, 6 months is the average time when solid foods begin to be introduced. Now, certain foods such as the milk, egg, nuts, fish, shellfish are more allergenic. They're more common allergies. In fact, these represent more than 90% of food allergies in all ages. So it is suggested that these foods, some special consideration should be made before these foods are introduced into the diet of a high-risk infant. For a breastfed infant who is developing eczema or is showing signs of an allergic reaction while breastfeeding, then there should be some consultation with an allergist to determine if they have been sensitized or become allergic to any of these foods while breastfeeding, because in fact an infant may be found to be allergic to peanut even if they've never ingested peanut, simply if they've been exposed through the breast milk of the mother. So before introducing that food into a high-risk infant, if that infant has conditions such as eczema, which is an allergic skin reaction, then they should be tested for these high-risk foods before they are introduced into the diet. The delayed introduction of highly allergenic foods has been recommended for many years and is now thought to be a controversial issue. For many years, it was thought that babies should not be exposed to peanut or shellfish or fish until they're around 3 or 4 years of age. The rationale behind this was at that point the baby's gut has matured to the point that it provides a more effective barrier to prevent those large proteins from passing through and causing an allergic reaction. However, it has been noted that in some cultures where these foods are a staple of the diet and are introduced very early in the age of the infant, that the presentation of peanut allergy or fish allergy is much less. So now there's some controversy as to whether or not this should be restricted. There probably are individual reasons to make these recommendations, and I would recommend that an allergist be consulted to guide a high-risk baby's parents on when they should introduce these types of foods into the diet. By 6 months of age, the amount of breast milk that a baby will ingest will not meet their requirement for the amount of protein and minerals and vitamins that are needed. And factors other than the age may be necessary to be considered in introducing complementary feedings in premature babies. So you need to know when you need to add supplements based on how the baby is growing and what other medical conditions the baby may have. There's rarely ever any need to introduce these complementary producing solid foods. The baby needs to be able to have a certain ability to get the food into their mouth and actually swallow the food. And usually when you first introduce solid foods, the baby is going to thrust it out of their mouth with their tongue. That doesn't necessarily mean that they don't like the food and they don't want to eat the food. They just need to be developed to the point where they're actually going to be able to take in the food and swallow it. And this is a developmental skill that's not going to be found in a baby less than 4 months of age. Now, as solid foods are introduced, you're going to need to reduce the amount of formula or human milk that the baby gets so that you don't cause an excessive weight gain and obesity. So as the babies increase their solid food, you're going to reduce formula to no more than 28 to 32 ounces of formula or human milk. Now, you can measure human milk if it's been pumped and you're giving it in a bottle. If the baby is nursing, you can't really measure it, but the baby is going to adjust according to their needs for nutrition. They're going to adjust when they're full. They're going to stop nursing. You're going to introduce single ingredient foods first, one at a time at intervals of 3 to 5 days. That gives you an opportunity to observe to see if the food is well tolerated before you add something different that the baby may be sensitive to. Generally, cereals are offered first as they provide a good source of iron and zinc, which are the nutrients that are most likely to be deficient in a diet of a baby that is being breastfed. The single grain cereals are used first, and rice cereal is the least allergenic. There's no evidence that delaying wheat will protect against wheat allergy. Cereal should be spoon-fed and not added to the bottle unless it's medically suggested, such as with reflux, and that is to prevent overfeeding and obesity. Strained fruits and vegetables are next added and should be offered at least once a day. Canned food should not be used for home preparation of infant foods, not only because of increased amounts of salt and sodium in the canned foods, but even for some of the absorption of the metals from the canned product that may be a contaminant of the food. After the infant has tolerated the individual components, then combination foods may be given. And fruit juice should be offered from a cup when the infant is older than 6 months and should be pasteurized. This is to prevent infections being introduced into the baby through the juice. So you use baby juices, and it's best if they're given in a cup. This helps to prevent dental caries or cavities. Now, what you want to avoid, you want to avoid foods that are a choking hazard. So any round, hard foods, such as nuts, grapes, raw carrots, round candies, these do not belong in the diet of an infant. Honey has been implicated in infantile botulism, and so honey is not recommended as a food for infants. And you don't want to use an unmodified cow's milk in children less than 12 months of age. Their intestinal tract is not equipped to digest an unmodified cow's milk properly. You don't need to give sugar-sweetened beverages to infants. Iron is a requirement for breastfed infants and for premature infants. For full-term infants that are formula-fed, they may not necessarily require iron supplementation. Fluoride is generally added around 6 months of age to help prevent dental caries or cavities. And also vitamin D, B12, and fat-soluble vitamins can be provided in a product such as polyvisol, which is a common vitamin supplement for infants. Now, let's talk about some of the other immune sensitivities that can occur other than the allergy antibody or IgE-mediated type of reaction. You can have a non-allergy antibody sensitivity to milk or soy, and we call this a food-induced colitis. It can be an enterocolitis that involves most of the intestinal tract, or you can have it involving the upper part of the intestinal tract or the lower part of the intestinal tract. These patients present with a lot of intestinal symptoms, such as vomiting, diarrhea, often bloody. They can become dehydrated, and they can go into shock and have their blood pressure lower. They don't gain weight well. And this is a chronic condition, and it can be often confused with allergy. Many of these babies end up getting tested to see if they are actually allergic to milk or soy, and the test often will come back negative because only the allergy antibody type of reaction to food can be diagnosed or predicted with a skin test. So you'll have a baby that is definitely sensitive and intolerant to milk or soy, but they don't have a positive allergy test. This type of condition does not tend to occur in breastfed infants, and it can occur with some solid foods, especially rice, but it's much more common in babies that have milk or soy. Babies who are sensitive to milk are at higher risk for developing this condition with solid foods. It tends to begin early in infancy, and the way that you actually will diagnose this is through what's called an oral food challenge, if you need to. If you have a very typical history or story of what's going on when the baby's eating, you don't actually have to do a food challenge. You would then eliminate the milk or eliminate the soy. These are children who end up being put on hypoallergenic formulas, such as those elemental formulas. You may want to delay the introduction of some cereal, especially rice cereal. And this tends to resolve spontaneously as the child gets older, usually by the age of 3 and often by the age of 2. The food allergy, the milk allergy, and the soy allergy and egg allergy, these are often outgrown as well. And infants who have milk allergy, again, usually by the age of 2 or 3, will outgrow this. This can be determined through their allergy evaluation before the introduction of these formulas or milk into the diet. Now, the proctitis is the lower part of the intestine. It doesn't involve the entire intestine, and this is a much milder type of condition. The babies usually are not as severely sick as those that have the enterocolitis, and they appear well, but they may just have some blood-tinged mucus in their stool. This can occur in infants who are breastfed or bottle-fed, and generally it's occurring in breastfed infants when their mother is ingesting milk or egg or corn or soy. This is not an allergy reaction, but it is an immune reaction that involves the rectum and large intestine. So in these infants, they're going to have a negative allergy test for milk as well. It usually presents early in infancy and usually is outgrown by 1 or 2 years of age. Another condition that is becoming more and more common is a condition that's called eosinophilic esophagitis. That's a long name, and we generally just call it EE. That's a lot easier to say. EE is a chronic inflammatory condition of the food pipe that's called the esophagus, and it's caused by the infiltration of certain types of allergy cells into that part of the food pipe. These allergy cells are called eosinophils, and eosinophils are the type of white blood cells that are produced in response to an allergy. In infants who get this EE, because their food pipe is inflamed, they have a lot of difficulty with feeding. They don't like to feed because it hurts when the solid food goes down, and they sometimes will have vomiting associated with it, and they tend to refuse feeding. They do better with drinking. They'll drink their milk okay, but it's more when you're trying to introduce solid foods that you're finding it very difficult. It's more common in males, and it can be a genetic predisposition in that we often will see it in siblings or we'll see it in children whose parents have had a similar condition. It's determined when the gastroenterologist or the doctor that specializes in stomach disorders passes a scope into the food pipe of the infant, and that's called endoscopy. When you put a scope in that food pipe, they can look at the food pipe. They see evidence of the inflammation. They see evidence of little rings and narrowing and swelling. And they do a little sample of the tissue called a biopsy. They look and they will see these eosinophil cells in the lining of the esophagus. One of the reasons why infants will get this is because of allergies. It can be associated with environmental allergies as well as food allergies. So allergy testing is very important because treatment involves avoiding the allergic foods. Some children who have this will also have a condition called celiac disease, which we'll talk about in a little while, and they often are tested for this. And these infants will also have problems with reflux. So treatment involves reducing these inflammatory cells in the esophagus. This is done through the use of topical steroid medication. There are steroid medications that are used for treatment of conditions like asthma that are given in a nebulizer. These are liquid steroids, and they're given in a form of a slushy that the infant will swallow. It's usually a slushy with some substance that is tolerated, like Splenda in some cases, but we don't like to always use Splenda in infants. We also can use yogurts and things like that, as long as the baby is not allergic to the milk product. And the baby will swallow this. The steroid will coat the esophagus, and it treats the inflammation to reduce the presence of the eosinophils. Medicine to reduce reflux is also used because the acids in the stomach, when they come up into the esophagus, can also cause a lot of inflammation. And, of course, avoiding any foods that the infant is found to be allergic to. Sometimes, because of the inflammation, the food pipe becomes very narrow, where it's very difficult to even get any swallowed food down, and in that case, the food pipe or the esophagus may need to be dilated. Now, celiac disease is also an immune condition that causes inflammation, though, of the small intestine, not of the food pipe. And it's caused by a sensitivity to gluten products, which include things such as wheat, rye, barley, oat. These are gluten products. This is diagnosed through a sample of the small intestine that shows a portion of the small intestine called the villi that are reduced in size, or what we call atrophy, or they are reduced in size and are not functioning. There's a blood test that kind of screens for this, but the absolute diagnosis is made through the biopsy. There is a genetic predisposition, meaning it tends to run in families, and the treatment is a gluten-free diet. A very rare condition called Highness Syndrome is another condition where the sensitivity to milk causes a reaction in the lung, where these babies tend to cough up blood and have breathing problems due to an inflammatory reaction in their lung from the milk. And this is a treatment is avoiding milk. So in summary, we know that human milk is the best source of nutrition for infants, and among the many benefits are some degree of protection against food allergies. The infants are at risk for allergies due to their immature gut and their immature immune system. The most common foods that cause allergies are milk, soy, and egg, and most of these food allergies are outgrown. It's difficult sometimes to recognize that there is an allergic reaction, but it's important for parents to be counseled on what to look for and when to recognize it. And once these food allergies have been diagnosed, strict avoidance is necessary, and epinephrine and antihistamines such as Benadryl should be on hand. Benadryl is available in a liquid form for infants, and it's fairly rapid acting. That's why the Benadryl is the recommended antihistamine to have on hand. There are a variety of food reactions that do not involve the allergic antibody that warrant special consideration. Many of the skin reactions that we see in infants are irritant reactions, and many of the adverse food reactions are non-allergic and are not diagnosed by skin testing. I hope you found this talk to be of value and of interest, and I'll be happy to answer any questions that you may have.
Thank you, Dr. Wilson, for that wonderful presentation. Participants, if you have any questions, please go ahead and type them in the chat box on the side of your screen. To kick things off, I do have one question. Dr. Wilson, you did mention in your presentation that breast milk has both beneficial properties as far as protecting against allergies, as well as, just general beneficial properties for the immune system. However, you also mentioned that breast milk has the potential of sensitizing an infant to negative substances or things that could cause a predisposition for allergies. In a situation where an infant has a family history of allergy and, the infant is at a higher risk of developing allergy, and the mother, for whatever reason, is unable to provide breast milk or is unable to produce it, what would be the recommendation then? Would the recommendation be to go straight to formula options, or would donor breast milk, even with the potential for sensitization, would that still be preferred over formula given the beneficial properties of breast milk?
Well, donor breast milk would be your next best step if you're not able to get breast milk directly from the mother. Donor breast milk may not always be readily available, but if it is available, then that would certainly be the next best recommendation. Breast milk in any form or however it's obtained through pumping, donor breast milk is always going to be preferable to any type of formula. If you have a baby who's had no symptoms yet, they have not developed anything that suggests that they already have a food allergy, and if there is no breast milk available, then it would be recommended to use just a standard infant formula. You're only going to want to go to the hypoallergenic elemental formulas if there have been symptoms suggesting a food intolerance or a food allergy.
Great. Thank you very much. So if there are no further questions, we will go ahead and end the session. I'd like to thank Dr. Wilson again for her wonderful presentation. If any of you have any further follow-up questions following this presentation, please feel free to reach out to me directly at info@pebblesofhope.org. You can also find us on the website at, again, www.pebblesofhope.org, and our contact information is there. I can field any questions to Dr. Wilson and get back to you with responses as well. Thank you so much, everyone, for your time, and thank you for your support of Pebbles of Hope.